Hi, everyone. Thank you to be here today with us for the lecture Revitalization, All You Want to Know by Professor Galler. Professor Galler, thank you so much to be with us today.
Hello.
Let me introduce you. So you obtained your degree in dentistry in Munich in 2000. You worked in private practice until 2002, and then you joined the Department of Conservative Dentistry and Periodontology in Regensburg at the University Hospital. You received your postdoctoral training at the University of Texas Health Science Center in Houston, and you earned your PhD, biomedical engineering from Rice University in Houston in 2009. After your return to Regensburg, you completed your habilitation and built your own research group as an associated professor to work on pulp biology, regeneration, and immune responses. You were summoned recently in the University of Nuremberg as a full professor and chair of Department of Conservative Dentistry and Periodontology. You were president of the Pulp Biology and Regeneration Group of IADR in 2013 and 14, and you are currently chair of the Research Committee of the European Society of Endodontology and member of the board of the German Society for Endodontology. You have led the committee for the ESC position statement on revitalization, and you published numerous articles. You have received several awards for your scientific work, and you have lectured nationally and internationally in clinical as well as scientific meetings. So it's a great honor to receive you today. Thank you again. We are here today for around 1 hour, made of 45 minutes of lecture. So this lecture is recorded. You will have subtitles in Spanish, but the lecture is in English. And then we will have a session of question and answers live with Professor Galler. Before launching the webinar, we want to hear from you. So I will launch some questions, 2 polls, and you can answer directly by clicking on it. I hope that everybody is ready. So we will start with the first question. I launch the polls. So how often do you use regenerative procedures? Please answer. I will close in 10 seconds. Thank you. So let's see the results. So we can see the results. What do you think about it, Professor Galler?
Well, very interesting. So there's more than half of our attendees today who use this not often, but regularly. And of course, the indication is very narrow. So it seems like we have a lot of people here today who have experience with this procedure. So that's quite good. Yeah.
Second question, and then we will launch the webinar. Second question, sorry. Some technical. What do you expect after a revitalization procedure? Please answer. Five minutes left. Thank you. I'm closing the polls and I share it with you.
That also looks very interesting. So radiographic evidence of healing of periapical lesion is the outcome that is expected the most. And during the course of this lecture, we will go into the outcomes in a bit more detail. So it looks good to me.
Great. So it was a good introduction to your lecture. So now we can launch the webinar. So see you in 45 minutes.
See you soon.
Sorry, a technical problem. Stay tuned.
Good evening, dear colleagues. It is a great pleasure for me to be part of this webinar today. And I want to talk about revitalization, and over the next 40 minutes or so, I will try to answer all the questions that you may have about this procedure. The topics that I want to cover today is, first of all, regenerative endodontics. What does this actually mean, the term, if we refer to regenerative endodontics? The second would be revitalization as a regenerative endodontic procedure, and I want to go into a bit of detail in regards to the indication, the procedure itself, the details of the clinical procedure, and then the evidence and outcome. And last but not least, in the third part of this lecture, I want to touch upon hydraulic calcium silicates as a material that we use during revitalization and give you some reasons why. I want to start with a commonplace endodontic therapy. So in my opinion, it already starts with selective caries removal because we already try then to maintain pulp vitality. Then surely pulp capping and also pulpotomy as the vital pulp treatment options are part of our endodontic therapy. The classical endodontic therapy is root canal treatment, where we remove remnant tissues, disinfect the canal system, and then obturate with a synthetic material. But at the end of the spectrum, I would set regenerative endodontic treatment as this treatment allows us to get tissue into the formerly empty root canal. Now, regenerative endodontics, what does this mean? I want to start with a quote. It's already from 2007 to explain what it means. Murray stated that regenerative endodontic procedures can be defined as biologically based procedures designed to replace damaged structures, including dentin and root structures, as well as cells of the pulp-dentin complex. A more recent quote I want to show you as well. It's by Kim from a review article of 2018. And it is stated there that the treatments and outcomes of regenerative endodontics are so different from traditional endodontic therapy. Therefore, it has attracted enormous interest and attention in the field of endodontics in recent years. And I can only confirm that there is an enormous interest in lectures about this topic, into the procedural details of the regenerative endodontics, and I want to cover a bit of this today. Now, what do we actually mean when we talk about regenerative endodontic treatment? It is actually this particular treatment where we induce in immature teeth with pulp necrosis a blood clot. It is therefore a biology-based treatment and the alternative treatment to the apical plug. You can see in the schematic, it's done in immature teeth, and the difference between the apical plug and this regenerative treatment is that after disinfection, we don't place a material in contact with the apical tissues, but we provoke bleeding and create a blood clot inside the root canal, which can function as a guide rail for the formation of new tissue. Now, this idea is not really new. If you go back into the literature, you can already find some of this back in the 1950s and 60s. And one of the first publications was by Nygaard Östby, who stated in this paper that it seems strange that in endodontic treatment, bleeding is more or less looked upon as a complication. And he wanted to propose to remove the entire pulp from the main canal and then allow the apical part of the canal to subsequently fill with blood. And that's what he did. There was instrumentation, and then he would obturate the coronal 2/3 and have the blood clot in the apical part. He did animal experiments, he did this in patients and did some histologic analysis. And he found that there is tissue ingrowth, but rather an ectopic tissue, not really pulp. And maybe unfortunately, this idea disappeared for decades, and there was more focus on instrumentation, on disinfection, and only more recently, this idea was rediscovered. But it never disappeared completely, or at least there was still a growth of knowledge, and part of this is derived from the dental traumatology literature. The paper I'm showing you here is also quite old, from 1978, and clinicians realized that if teeth were avulsed and replanted, if the apical foramen was open, if the tooth was immature, there was a chance that tissue ingrowth would take place, that blood vessels would grow into this empty canal. And what you can see here are images from animal experiments in dogs, and depicted are blood vessels after staining. And in this experiment, teeth were extracted, replanted, and then histology was performed after 4 days and 3 weeks. And you can see here the control, the tooth as it is healthy. And then after extraction and replantation, and you see the blood vessel ingrowth after 4 days and after 3 weeks. And at this stage, the blood vessels have already reached the coronal aspects of the canal. Furthermore, what was found in these experiments is that if the pulp tissue was left in situ before before transplantation or implantation, that more tissue ingrowth was expected or observed compared to those teeth where the pulp tissue was removed. And we can explain this in one way because the tissue, even though it becomes necrotic, is maybe a sort of guide rail again, as cells don't like to grow into empty spaces. And the second explanation would be that the cells that become necrotic then send strong signaling molecules that that oxygen is needed and nutrients are needed. And these signaling molecules then create a strong stimulator for new blood vessel formation and ingrowth. This term of revascularization was then also used in a slightly different context, and I want to show you here the first case report dealing with this provocation of bleeding, which really caught the interest of the Endodontic Society. So in this case, a lower premolar presents here with periradicular periodontitis. There is a sinus tract. There was swelling and pus drained from the tooth after the creation of the access cavity. Now, if you look at these very thin walls here of this premolar, you would also ask yourself, what kind of options do we have? Do we want to place MTA in contact with the apical tissues? There might be a risk of fracture of these thin walls, and what was done indeed was that after disinfection with sodium hypochlorite and a triple antibiotic paste, provocation of bleeding was performed. So a blood clot was created inside this root canal here. The clot was covered with MTA and the tooth was sealed, and you can go back to the original publication and look at several more radiographs, but I want to show you only the last recall after 24 months, and you can clearly see that not only has the periapical lesion healed completely, but there is significant increase of root length and root thickness, and thus completion of root formation. Now, this was really new, and people were stunned and thought, okay, now we can regenerate the dental pulp. It has to be pulp tissue that leads to the completion of root formation in this case. The terminology now has changed a bit. The early cases were termed revascularization, as it referred to the ingrowth of tissue in these immature teeth. But then soon after, regenerative endodontic procedure was the term that was coined because of this hypothesis that we could really regenerate the dental pulp with this procedure. More recently, the ESC used the term revitalization because it is a more neutral term that doesn't really imply that it is true regeneration that we induce, and I'm going to talk about this in a bit more detail. And lately, the term guided endodontic repair has appeared in the literature, indicating that maybe it's a repair process and not a true regenerative process. Now, do we have evidence of this procedure? Since the publication of Banch and Trope, time has passed, and actually the field has actively created evidence to fill all the slots of this pyramid of evidence. And after the first in vitro studies and case reports, case series were published, then cohort studies, retrospective, prospective, and eventually also quite a number of randomized controlled clinical trials. And we do have today meta-analysis and systematic reviews. So really a sound body of evidence to support this procedure. Now, coming back to the question, regeneration or repair, I want to first actually go back to the definition of the term of regeneration. And the definition is that it's the ability of the organism to restore damaged or lost cells, tissues, or organs. And not only restore them, but restore them to their original architecture and function. And you all know the salamander, which is able to regrow limbs. Now, the human body is not so good in regeneration if tissues become damaged to a certain extent. We will then, in many tissues, observe the formation of an ectopic tissue and scarring, and this is shown here by the example of a skin wound. So the question remains, is it regeneration or repair that we induce? But before I answer this question, I want to first go into the procedure of revitalization, as we would term it today, and come back to the indication. I mentioned in the start that it's indicated in immature teeth after pulp necrosis. And in these teeth, we have specific structures still present, which disappear once root formation is complete. And if you look at this immature tooth here with these very thin dentinal walls, we know that we have HERS, Hertwig's epithelial root sheath. You see these epithelial cells here, which determine the fate of the underlying mesenchymal cells. They instruct them to become pulp cells, odontoblasts, and to form dentin. And these underlying cells are the cells of the so-called apical papilla. This is a stem cell niche that is present as long as the root formation is incomplete. And what we do with the procedure when we provoke the bleeding into the canal is that we transport stem cells from the apical papilla into the canal. So this was the hypothesis for this procedure. And if we can transport these cells of the apical papilla into the root canal after provocation of bleeding, there are several expectations. which would be that there is proliferation and differentiation of these stem cells, and that they could eventually then form new tissue and regenerate the dental pulp. The second expectation would be that if we have pulp tissue there, we get a response to cold testing or to sensibility testing, could also be electrical pulp testing. The third expectation would be the completion of root formation and therefore a strengthening of the thin root walls and thus a decreased risk of fracture. The last expectation, but most importantly, I believe, would be the healing of the periapical lesions, and the case I showed you before actually fulfills these expectations to a great extent. In 2016, the European Society of Endodontology published a position statement about revitalization procedures, and if you're interested, you can read up all the details on the case selection, the clinical diagnostics, the procedure, then the recalls, the definition of success, and the outcome. All of this is stated in this position statement. And I want to go over the procedure with you, show you some of these details. And in this schematic, you can just see again how revitalization would work, that we create this blood clot. Then optionally, we can place a collagen matrix on top of the clot. The collagen matrix can facilitate the placement of a hydraulic calcium silicate cement, which is supposed to be placed on top. And then there's the adhesive seal of the tooth. Now, the details of the procedure are as follows. During the first visit, we would do local anesthesia, which is optional in that case. We would isolate with rubber dam and create the access cavity. And then it's really about disinfection. We need to remove the necrotic tissue. We need to disrupt the biofilm. But there should be minimum instrumentation of the canal walls, as we don't want to weaken the walls further. The irrigation is done with lower concentrations of sodium hypochlorite, followed by EDTA. As an intracanal medicament, calcium hydroxide is recommended, and it should stay there for 2 to 4 weeks. We do a temporary seal in the meantime. During the second visit, we would work with local anesthesia, and we can choose whether to do it with vasoconstrictor or not. If we use a vasoconstrictor, it's harder to induce the bleeding, and if we don't use it, it might be more painful to our patients. And you have to really see how compliant the kids are, preferably during the first visit, in order to assess how you can perform the procedure. So the compliance of the patient is quite important in this case. After rubber dam and re-access, the irrigation is now done with EDTA only, and I'm going to explain why in a little bit. And then we dry the canal, just remove the excess liquid with paper tips, paper points, and then we provoke this bleeding, which can be done with a hand file in an up and down movement, or we can also bend the tip of the file into a little loop and rotate the file inside the canal, and then the blood clot should reach up about 2 millimeters below the cement to enamel junction. A collagen matrix can then be placed on top of the blood clot, which you can see here in this image, and then it is covered with a hydraulic calcium silicate. In this case, it was biodentin, and then the adhesive seal follows. So the biofilm is certainly something that is an obstacle for us, and I want to show you another quote. Ashraf Fouad, who has published extensively in microbiology and endodontics and also in regenerative endodontic procedures, stated some years ago that considering that revitalization procedures ultimately aim at regenerating the dentin pulp complex, the level of disinfection required is anticipated to be higher than that accepted for conventional root canal treatment. And during the past years, this kind of proved to be true. I'm going to show you some more data a bit later. But the disinfection protocol is surely very important. We do it with sodium hypochlorite as for conventional root canal treatment, but at lower concentrations between 1.5 to 3%. And this goes back to some in vitro studies that were done by Aníbal Diogenes group in San Antonio. They have published a lot on regenerative endodontics in general. And they exposed these stem cells of the apical papilla or scap to sodium hypochlorite. And you can clearly see that sodium hypochlorite is toxic. And if you go to higher concentration, it's even more toxic. It also reduces the differentiation of these cells, but the good news is that if you use EDTA afterwards, this effect is partially reversed. Now, if we look at the effects of the EDTA, it not only neutralizes the effects of sodium hypochlorite, but it also releases growth factors from the dentin matrix. EDTA, as you know, demineralizes the dentin surface, and what happens then is an exposure of the collagen structures underneath, and as within the dentin matrix growth factors are bound, these are now exposed on the surface after this demineralization process, and this can be visualized, which you can see in this SEM, scanning electron microscopic image, where we treated the dentin surface with EDTA and then used antibodies which were labeled with little gold nanoparticles. And you can see these dots here. These are not random or artifacts. These are really bound where a certain growth factor, TGF-beta1, is exposed on the dentin surface after treatment with EDTA. And then I want to show you some histologic images from an animal experiment we did, where we used tooth roots and seeded dental pulp stem cells in a scaffold material into the root canals. And if you treat the dentin with sodium hypochlorite only, it's quite disturbing that you get this massive resorption process at the interface of the cells towards the dentin. We repeated this experiment and treated the dentin with EDTA as the last step. And you see this big difference where the cells actually attach to the dentinal wall. They extend processes into the dentinal tubules and form this very nice intimate association with the dentin at this interface. And what looks like regular pulp tissue here is really a tissue engineered pulp, and the treatment of the dentin with EDTA makes a really big difference in this type of experiment. What about intracanal medication? In many of the first case reports and even in some of the clinical studies, an intracanal medicament of a triple antibiotic paste was used, which consisted of ciprofloxacin, metronidazole, and minocycline. And this is actually, I guess, for historic reasons. So there are publications by the group of Hoshino who showed that this mixture is very effective against bacteria, both in vitro and in vivo. And he did some experiments in primary teeth. And we know that it's a very potent mix, but there are problems associated with the use of antibiotics in these cases. There is a big discoloration potential, and this is why minocycline, which was responsible for the discoloration, was actually later on removed from the mix and then replaced with cefuroxime, as you can see here in this mixture. But also the concentration is actually very high. It's uncontrolled. We just mix a paste from these three antibiotics. There is certainly cytotoxicity, and there are issues with sensitization or maybe formation of resistance. And also the removability from the canal might be an issue. And after quite some discussions, now the recommendations by the larger endodontic societies are to use calcium hydroxide. And the antibiotic pastes are the second choice if the clinical signs and symptoms of inflammation do not recede after treatment with calcium hydroxide. Now, what kind of outcomes do we expect from this procedure? I want to show you success rates here, and this is in comparison with the apical plug, which is the second treatment option. If we look at the signs and symptoms, if we look at the resolution of radiolucencies and survival, both revitalization and the MTA plug are equally good. If we look at apical closure, it is less in revitalization, but more frequent with the apical plug. And if we look at the increase of root length and thickness, we can see that this is far more frequent with a revitalization, especially the root thickness doesn't really increase if we place an apical plug. Now, what about this completion of root formation that I showed you in this first case by Banches and Tropes, which really got our hopes up? I want to show you a clinical case that I treated. It was this 8-year-old girl. She had an accident and a complicated crown fracture of her upper left incisor. And unfortunately, during the emergency treatment, the pulp was removed. It should have been treated with vital pulp treatments. The parents were not too happy, and they did some research, and they came to our clinic in Regensburg to ask after revitalization. Now, it's the immature tooth. The first thing that we did was to reattach the fragment, and then you can see the images after the revitalization procedure and then the recalls. And if you look at the root walls, you might see that the root canal is a bit more narrow compared to the postoperative image, but in terms of root length or apical closure, nothing actually has happened. Why is that? We don't see this regeneration? Well, what we actually have known for quite some time from animal experiments is what happens in the apical area is not regeneration, but for example, a position of cementum, which radiographically looks like an increase of the root wall thickness. And there can also be bone ingrowth, ectopic tissue formation inside the root canal. And one case was published from a human tooth after revitalization. The patient had another trauma 18 months after the revitalization procedure, and the tooth was extracted. It couldn't be restored. And the histology shows that there is this mineralized tissue inside the root canal, but not really pulpal tissue. So in most cases, there is no regeneration, but there is healing, and there's a biological root canal filling. And the patient case I showed you before, both the patient and the parents and myself, we were actually very pleased with the result still. Now I want to show you one more case that was published also out of San Antonio, and it is about this premolar with a wide open apex, and cone beam CTs were done during the course of this treatment. You can see the postoperative image, you can see the recalls with the CBCT scans, you can see that there is clearly a narrowing of the root canal and a completion of root formation. And the tooth was later extracted for orthodontic reasons, and histology was done. And here you can actually see a very nice image of this pulp-like tissue with what seems like an odontoblast layer and the formation, the new formation of tubular dentin. And therefore the author stated that they demonstrated here for the first time regeneration of a pulp dentin complex after a regenerative endodontic procedure. Now we have to take a closer look at the case. It looks very similar to the case I showed you by Banches and Trope. And these teeth, these premolars, are very rare. They are dentis evaginati. This is a structural anomaly where there is a connection between the oral cavity and the pulpal space. Therefore, there is bacterial infection over time. And the reason why there might actually be regeneration, that in these cases, some islands of pulpal tissue remain despite this infection. And if there are some remnants of the original pulp tissue, actually this tissue can induce the formation of pulp again. So it's kind of an exception, So we can see regeneration in some rare cases with this specific condition, but probably not in our trauma cases that we usually treat. So most of the cases we treat with revitalization are the trauma cases. Now I want to comment on one more thing, which is the effect of residual bacteria on the outcome of pulp regeneration. And this is a paper also out of Ashraf Fuad's group, who I've mentioned before. And they did a very nice animal experiment. And they induced periapical lesions in ferrets, then did disinfection with sodium hypochlorite and the triple antibiotic paste. And they, which is not so important in this context, had two groups, one with scaffolds and one with a traditional blood clot. And then they did radiographic and histologic evaluation after 3 months. And I want to show you some images here. So you can see the ferret tooth with the very thin walls here. And you can see this histologically with these thin dentin walls and the ingrowth of bony tissue. You see very nice tissue formation here, and you see apposition of mineralized tissue towards the existing root walls. On the other hand, if there is bacteria present, residual bacteria present, there is no mineral apposition whatsoever. And this was really the finding of this paper, that the presence of residual bacteria is significantly associated with a lack of radiographic growth, and that the amount of mineralized tissue formed in teeth with residual bacteria was significantly less. Even in cases where there was no radiographic evidence of the inflammation, but only the histologic evidence. So residual bacteria may actually be one of the main culprits if we don't see any apposition of hard tissue. Now I want to come to the success criteria. So how do we actually evaluate the success? I told you about the expectations that we had in the beginning, and can we now, if we don't regenerate the pulp, if there is no completion of root formation, say that this is not a success? As we have learned over time, the success criteria have been changed and modified, and I think that the AAE states very reasonable success criteria, where the primary and essential goal would be the elimination of symptoms and the evidence of bony healing. The secondary or desirable goal would be the increased root ball thickness and or increased root length. And the tertiary goal, which is optional, the positive response to vitality testing. How often do we achieve success? The primary goal can reliably be achieved with high probabilities between 91 and 94%, and therefore the success rates for this treatment are quite high. Now I want to give you some perspectives also for this treatment, and one would be a case that I treated myself many years ago. And it was, again, a case of dental trauma. It was this boy, 8 years old, and the dentist treated it and did his best, did the follow-ups, and it looked okay. But after a while, the boy had complaints and was in pain, and he came back to the dentist's office. And the dentist then filled the canal with MTA, which is in principle maybe not a bad idea. But then the boy developed this sinus tract as a sign of a chronic infection, and the dentist referred the patient to our clinic. And after removal of this MTA inside the root canal, this is what we found. So there was an extensive internal resorption, and it was in fact my first case of revitalization, because in this case you don't really have so many options. If you want to fill this again with MTA, you might actually perforate and break these thin walls. And this minimally invasive treatment with the provocation of bleeding appeared to be the most promising in this case. And you can see a follow-up image here and the radiographs, and it's been 8 years by now. The situation seems fairly stable. Maybe there is a bit of a position of hard tissue here. I'm not sure what is going on here, if this is perforated or if there's still a thin wall. I would hope so. It looks a little bit like the periodontal ligament space is continuous here. The tooth is in function and there is no problems. The only thing that we decided is that it should not be moved during orthodontic treatment. So I was in communication with the orthodontist in order to not endanger the status quo. However, we don't really know what the long-term perspective of the tooth is going to be. On the other hand, if we have really saved the tooth for so many years and gotten the boy over these critical years, then it's maybe less of a loss if it really is lost in the future. Then some more perspectives. One is that revitalization is possible also in mature teeth, and there are more and more studies published on this topic. You can see some radiographs here, an incisor with this very big lesion, and then 60 months of the revitalization. Of course, you can argue what is the benefit here because it's a mature tooth and root formation is complete, but you could think of this biological root canal filling, that there is an immune response of this tissue, that you don't need to have a synthetic material inside the root canal, and this might really be attractive for many of our patients. And there is even a recent systematic review on this topic, and it is stated in this paper that based on the moderate quality evidence we have so far, regenerative endodontic procedures appear as a viable treatment alternative for mature necrotic teeth with periapical lesions. Now, I promised to, in the end, also talk a bit about the materials, about the hydraulic calcium silicates that we use during revitalization procedures. And why do we use them? Well, there is this recommendation in the ESC position statement where it is recommended to place a hydraulic silicate cement on top of the collagen matrix in a thin homogeneous layer, and that the practitioner should be aware of the potential discoloration after contact of the material with blood. So it is recommended in the position statement. Why? Let's see. So hydraulic calcium silicates, what are they? These materials contain dicalcium and tricalcium silicate, as you're probably aware. And these silicates react with water to form calcium silicate hydrate and also calcium hydroxide during setting. And the particular thing about hydraulic calcium silicates is that they actually set and develop their properties in contact with water or other fluids. And this is it makes them quite different and distinct from the materials that we usually use in dentistry, because they all don't like water at all, and they don't perform if they get in contact with water or blood or saliva. Hydraulic calcium silicates are actually known from the building industry as Portland cement. And if you see something like this, so apparently this is China's longest bridge, so these pillars here are made from these type of materials as they set also underwater, and this is why they are called hydraulic. Now, if we look into dentistry, MTA as the first hydraulic calcium silicate was introduced in the 1990s for root end resections, and MTA is a Portland cement-based material. And the original formulations, for example, the ProRoot MTA had this long setting time, difficult handling, and really high cost. And also bismuth oxide as a radiopacifier with a high discoloration potential. By now, as you know, there are many different products on the market. I'm not really an expert on these calcium silicates in all their diversity, but if you pick one, you should really know the properties of your material. And one material that I actually use quite a lot is biodentin. And it has the advantage to be a synthetic material that is made from laboratory grade tricalcium silicate, so it doesn't contain any trace elements as the Portland-based material. It has zirconium oxide as a radiopacifier. So a drawback is that the radiopacity is not as high as for the MTA, for example, but it has a significantly lower discoloration potential because of that. Biodentin, the liquid contains calcium chloride as an accelerator, so the material sets within 8 to 12 minutes, and it contains water-soluble polymers for improved handling and physical properties. Here I want to show you the surface of a hydraulic calcium silicate on the left-hand side after incubation with cell culture media, so after contact with a physiological fluid. And this is a very nice SEM image, which was done by my colleague Matthias Wittbiller. And you can identify these different materials and crystals here. You can see the calcium silicate hydrate. It has this spiky shape. You can see platelets of calcium hydroxide here, for example. Then these flowers of calcium phosphate and these more squarish shaped calcite crystals. If we seed cells on top of the surface, you can see here on the right-hand side that the cells really flow into the material. They attach very well, and this is really an indicator for the high biocompatibility of these materials that the cells really like. So hydraulic calcium silicates have a scientifically proven biocompatibility. They show antibacterial properties as they release calcium hydroxide, so they're also alkaline as the calcium hydroxide. They suppress inflammation and support healing, and I'm not going to comment very much about that, but there are the respective papers that you can look into, and that the hydraulic calcium silicates, that they induce certain signaling molecules in the cells that will be anti-inflammatory and thus support the healing of the tissues. And some studies on direct pulp capping and bridging have also shown that these materials support mineralization and lead to the formation of a dentin bridge. Also, there is actually a lack of suitable alternatives in the case of revitalization. There might be materials that are suited better, but we don't have them at the moment, and someone would actually have to develop them. And now at the end, I want to show you some recent data that we compiled from a retrospective clinical study on a comparison of biodentin and MTA after revitalization procedures. And what we did here is that we collected radiographs after revitalization from expert clinicians from several different countries. And then we analyzed cases of biodentin and of MTA. And then we did a alignment method. We aligned the radiographs, the postoperative radiographs with the recall radiographs in order to be able to perform reliable measurements of the root length, the thickness, area of the root walls, and also the area of the root canal. And I want to show you these examples here. So this would be measurement of the length, the thickness at different positions of the root wall, and then some areas, the root walls, and also the root canal, which can be calculated here by subtraction. After the measurements, we did the statistical analysis with non-parametric statistical tests. And I want to show you some of the results here. What you can see here is that the root length postoperatively was set to 100%. And if we look at the different recalls compared to the post-op radiograph, you can see that there's an increase of root length, which becomes statistically significant at the third recall interval for biodentin. And MTA data are similar. It is maybe a bit more pronounced, the effect. And for root thickness, we see similar results, an increase over time with the biodentin and as well with the MTA. So there was a continuous increase of root length and thickness for both materials without any statistically significant differences between the two materials. If we look at the area of the root walls, we can see a similar effect, an increase over time, both for biodentin and for the MTA, and the area of the root canal would then decrease as a logical consequence for both materials. So we observed similar behavior for both the materials. Again, there were no significant differences between biodentin and MTA. Some more results include that apical lesions would heal with both materials. So we had 10 cases with periapical lesions present prior to treatment, and they healed in all cases. But there was a marked difference in terms of discoloration. So after the use of MTA, there was visible discoloration in 74% of the cases. With biodentin, it was only 18%. Also, you have to be aware that the increase of root length and apical closure was not observed in about 1/3 of all the cases. So we can see the increase if we look at the whole population or the whole all our specimens, but there was about 1/3 where we did neither observe root length increase nor root thickness or apical closure. So it is really not predictable whether this is going to happen or not. But what we can conclude from the study is that MTA and biodentin are both suitable to cover the blood clot during revitalization, and you can see that due to the lower discoloration potential, biodentin shows some advantage in this aspect. In summary, for the whole presentation, I want to state that revitalization is an alternative treatment to the apical plug, as I showed you during this talk. The success rates of both treatments are similar. The revitalization is less invasive, and it's really a biology-based treatment method with this induction of the blood clot. And we have seen that root maturation is a possible outcome in about 2/3 of the cases, but it's variable and it's also not predictable. Revitalization induces mostly repair and not regeneration. And I do see great potential for a biological root canal filling in mature teeth with this treatment, and would believe that in the near future we will incorporate this procedure more and more also into our endodontic treatment spectrum, maybe on a very individual basis, but still I guess that there is potential for more. And with this summary, I want to thank you all for your attention. I want to thank my collaborators on the clinical study, the funding sources for the general research, and I would be very happy to take your questions that you might have in order to really cover all you want to know about revitalization. So thank you, and I'm looking forward to your questions.
So thank you, Professor Galler, for your highly illustrated lecture. It was very interesting to see the history of a procedure, and I really appreciate that you have shared with us the perspective in mature teeth and your recent data from your retrospective study. Before going to the questions, I would like to know if your interest in the regeneration procedure has changed. You remember that I asked you during the last poll if you use this procedure. So let's try to see if during the webinar some change your mind. You were a majority to use it. So please, how often will you use regenerative procedure now? Five minutes left. Thank you. So it's still the majority with from time to time. What do you think, Professor Galler?
Yeah, I think it's just because the indication is so narrow, right? If you follow the recommendations that are in place today, it's recommended in immature teeth. And even in our clinic, even though we do see quite a bit of trauma cases, it's not a routine treatment still.
Thank you. So let's see the questions. I think that question just arrived. Could you tell us, so first question, could you tell us, do you prescribe MTA For direct pulp capping on milk teeth.
Oh, okay. So I'm not really an expert on primary teeth and pediatric dentistry in that sense, but it is surely for permanent teeth the material of choice, or hydraulic calcium silicates in general, whether it's MTA or a biodentin or any of the other products on the market. It's the material of choice in direct contact with the pulp, and I would think that the same is true for deciduous teeth as well. And actually the level of evidence is quite good by now, not so much for the pulpotomy. There you don't see such a distinct difference between a calcium hydroxide and a hydraulic calcium silicate, but in particular in direct contact with the pulp, I would always choose a hydraulic calcium silicate.
What is your perspective on single visit regenerative procedures?
Yeah, that's actually a very good question. And there are some cases in the literature where people have done the single visit. We do know that for conventional endodontic treatment, there is no difference. There is no evidence for any difference between a single visit and a multiple visit endodontic treatment. I would be rather skeptical about the regenerative approach to do this in a one-step procedure. And the reason for that is, if you have an acute inflammation in the tissues and you induce a blood clot, then you will also get the mediators, those inflammatory molecules, the cytokines, into the root canal with your blood clot. So my guess is, and I don't have evidence, but we can maybe deduct this, that if we have an inflammatory process going on, that the repair or regeneration may not function as well in this inflammatory environment compared to if you have done your disinfection, if you have done your intracanal medication, and the inflammation has gone down. I would think that then you have a better environment for healing in that particular case.
Why is it important to have a positive cold response?
For the revitalization, it's not important. It's not really a success criteria. So we also know from dental traumatology that in some cases, even though you have a vital pulp, you don't get a response to the cold testing because maybe the nerve fibers don't regenerate or repair as we would expect. So it shouldn't be a success criteria, but I would still think that, of course, if you do get a response, and we know from the literature that in about 50 to 60% of the cases you get a response to the testing, it's kind of a confirmation of what you have done, and it's a nice result to see as a clinician that there is some reaction, because it gives you another hint that there is vital tissue inside the root canal.
There are lots of questions regarding the bleeding. So how do you induce the bleeding, and how do you control it?
Yeah. So what I usually is I use a hand file and I do like this up and down movement, or you can also make a little loop at the tip and you can rotate the file. It is not easy to induce the bleeding, in particular if there is no more inflammation. So actually, if you can induce the bleeding easily, it might be a hint that there is still inflammation there, and you know this from conventional endodontic treatment as well, that you don't want to have any bleeding, you don't want to have any exudate, because it's maybe a sign of inflammation. So sometimes you have to repeat this several times, and then you watch, is the blood coming up? So you have your microscope and you can observe what's going on inside the canal, and then you maybe repeat this induction of bleeding. You rarely have the problem that you have too much blood. Sometimes you cannot even induce enough bleeding, and then it becomes more of an apical plug, actually. And for the patients, because they're usually small patients, if it's painful, at some point they they're no longer cooperative, and then you have to take a quick decision to maybe not continue with this induction of bleeding. And something that I find quite interesting, if you discuss this procedure with colleagues, it might actually make a difference whether you use an antibiotic paste or calcium hydroxide, because if you use calcium hydroxide as an intracanal medicament and you have this in contact with the apical tissues, the induction of bleeding might be harder compared to the antibiotic pastes.
A very precise question. Would you do regenerative treatment in a case where an immature tooth was open for about 6 months and referred to you after someone started the root canal treatment?
Actually, this shouldn't be a problem. The disinfection is really the important part, but still after 6 months, if maybe there's an intracanal medicament and the treatment has been postponed, you could still just redo the disinfection, place an intracanal medicament for a couple of weeks, and then induce the bleeding. I guess in terms of outcome, it's not going to be that different, which also tells you that there is no need for immediate action. So you still have time to do this. Even if you can still after 6 months decide whether you want to do an apical plug, whether you want to do the induction of bleeding. It's possible, yeah.
Some question regarding the mature teeth, because you spoke about it in the perspective. So if you would use this technique in mature teeth, is there a minimum size of the apical master file that is recommended?
That is also a very good question, and I guess we don't know. So surely the probability of tissue ingrowth will increase with an increased apical diameter. And if you look at the literature, in some of the cases, they prepare to an apical size 30, in some of the cases to an apical size 60. And there are animal studies which are actually older, where they found that 0.7 millimeters, so an ISO 70 would be kind of a critical diameter for the tissue ingrowth. And we have done some recent animal experiments for a tissue engineering approach and did different diameters at the apical foramen. And we observed that actually a 90 is kind of a critical size. So yes, it probably influences your outcome, but it's just probabilities, and cells in principle are very small, so they can enter through a narrow space. What I also believe is important in this context is not only the size of the apical foramen or the diameter that you create in mature teeth, that you have to create in the mature teeth, but it's also the length of the root canal. So the distance that the tissue has to grow, that the tissue has to bridge, will probably also play a role. So I guess I cannot answer the question very precisely, but just give you some indicators or probabilities what might play a role in this context.
Some question regarding irrigant. Do you activate your irrigant during the first visit?
So the activation of the irrigant is recommended. What you want to achieve is a thorough disinfection. It's very important. It's probably the key to success, in particular if you expect repair or regeneration. On the other hand, you have a very large canal. And what I'm telling you now is very subjective. In my immature teeth, I do not activate because there is a large contact area with the apical tissues, but it's fully okay to activate the irrigation solution in order to maximize your disinfection. I usually just do a very thorough irrigation protocol, and I don't instrument the walls, but I try to disrupt the biofilm with the file inside the canal, and just do the irrigation very thoroughly with high volumes and over extended period of time.
And I think it will be the last question. What are the precautions to be taken for extracting revitalized tooth in the future?
I'm not sure I understand the question correctly. Is it about the prognosis, or?
If you extract a tooth, a revitalized tooth, if you extract it.
Well, why would you extract it? You would extract it because it's a failure, because there is maybe resorption, or maybe there is internal replacement resorption. So there is probably a reason why you would extract, or maybe do a decoronation, because usually it's trauma cases that you use this procedure. If you have a failure because of inflammation, because the disinfection protocol was maybe not sufficient, you can still redo the case. You can still go back in, you can disinfect again and choose whatever endodontic procedure you have. And if you have to extract the tooth, it will be the same as maybe for an apical plug. If you get a fracture of the walls or something like this, a complication that you cannot handle other by extraction, then you just have to see what is the age of the patient and which options do I have to replace the tooth. Can we do an orthodontic treatment and maybe move teeth into the position of the lost tooth? Can we do a bonded bridge to replace the tooth? And as for implants in our young patients, that's an option that comes quite late. So we would always try to postpone an implantation as much as possible. I hope that answered the question. I'm not exactly sure.
Thank you, Professor. Thank you all for attending this session. You can watch the replay. We will send you the link. You will have a possibility to see it again. Thank you so much, and stay tuned for the next webinar. Thank you.
Well, thank you all for listening. It was my pleasure to be part of this webinar. And now I hope you'll all have a nice evening, or if you're watching from somewhere else where it's not evening, like here in Germany, where I'm sitting in my office, then I wish you all a good day. Bye-bye.
Bye-bye.